We'll move on to the next session by Dr. Mahendra Narwaria on redo bariatric surgery.
Thank you. I want to thank the organizers of this conference. There were so many years I was fighting to have a bariatric lecture in ISG, and almost every GBM I used to stand and say, I'm happy today that they are keeping a session. Not only today, we have one session tomorrow as well. So I'm glad that they accepted this also as a GI surgery. They were counting it otherwise a cosmetic surgery. So I'll talk about revision surgery or redo surgery in bariatrics. So revision surgery can be categorized as a conversion wherein we convert the procedure from its index procedure to some other procedure. It can be corrective to address the complications or having an incomplete treatment by effect of the previous bariatric surgery, or it can be reversal to a normal anatomy. That is mainly usually we do when we get patient with reactive hypoglycemia, which is not possible to treat by medical management. Revision bariatric surgery may be indicated in complication affecting the quality of life, which are recalcitrant to the conservative therapy and failure to lose or maintain adequate weight or weight regain, and to correct the severe metabolic or nutritional complications, sometimes which can arise because of the primary surgery. Reoperative bariatric surgery is an intricately complex and demanding area which require considerable primary bariatric surgical experience. Revision surgery, although technically challenging, can or may produce desirable outcome if performed on the right patient in the right timing and of course by a right surgeon. So as Dr. Tamannas has shown some complication, this is a complication of sleeve leak. So this is almost a 17-year-old video wherein I had seen maybe my second leak of my life, wherein there was no mega stent or endoscopic stents were available, and I encountered this. And those days people were not even doing so many sleeves in our country. So I decided to convert this into Roux-en-Y gastric bypass after the leak. So you can see the inflamed stomach, leak area. Again, most common site for leak is GE junction, near the GE junction, because that is the thinnest part of the stomach, which can have ischemia or sometimes we can fire the staple at the GE junction itself. So I mobilize the pouch, then Roux-en-Y Roux limb is prepared, dividing the jejunum about 100 centimeter from the DJ flexor. This is jejunal anastomosis in the infracochlear compartment. Then I'll take this limb, jejunum, up to G junction above the leak site, so that we are covering the leak area completely by a serosal patch, and that too in a 2 layers. So this is first layer, seromuscular layer, which is, so we have completely covered the whole length of the pouch. We opened the leak site, widened it to create a stoma there itself. And this I prefer to do a hands-on anastomosis because the tissue is quite edematous and we may not get good result with the stapler, and otherwise also the site is already opened. This is a Vicryl. I am using an endostitch device for suturing since so many years, and I am comfortable with it. So after completing the posterior layer through and through, this is a through and through layer anteriorly, full thickness, and then one more layer of seromuscular after this. I did a feeding jejunostomy also in this case, in case if it leaks, just as a precaution, but to my surprise, we could avoid a leak. This is another case wherein as patient was operated outside, who was a chronic smoker who presented with GI bleed, which was controlled by endotherapy. Then patient developed stricture, which was dilated twice by endoscopy, and when he developed stricture again, the endoscopist has placed a stent so that it will remain dilated with the help of stent, and that stent also migrated. Then this patient was referred to me for a revision surgery, and to my surprise, he had actually large ulcer which was perforated posteriorly, which was causing repeated stricture. So you can see, and there was a suture line also. The non-absorbed suture which are present in the anastomosis are usually not allow ulcer to heal. So there are dense adhesions there with the posterior remnant stomach. But luckily there was no gastrogastric fistula. Sometimes one can have a gastrogastric fistula with this, wherein they can have a weight regain as issue. So look at the thickness and fibrosis of the tissue, which is quite significant. That shows that it is a very chronic inflammation which has caused so much of fibrosis. So this is the gastrojejuno anastomosis is dismantled, the stomach pouch is further dissected. You can see the significant adhesions behind this. Now I decided to resect this part. There is some serosal loss here, but it was manageable. So we separated the remnant stomach. Now you look at the anastomotic site with the buoy and so many sutures present there at the anastomosis. And this is a resection of this ulcer bearing area or strictured anastomosis. So which was completely resected using a stapler, the green cartridge or black cartridge. And now I am further mobilizing so that we can do a tension free anastomosis with the jejunum. Now you can see the jejunum which we dismantled with the ulcer area there also. So we will excise this, dissect this. This is just to trace the length of the jejunum. Ideally we should have more than 60 centimeter of the jejunum so that we can avoid reflux. So this is significant length of ruling which is available. You can see we have gone up to JJ and then we resected. So this small part of the jejunal limb is resected. And then we take the loop up and do the anastomosis again. Again, my technique is always 4-layer anastomosis. First is seromuscular, which is much more secure anastomosis, and so far, and more than almost 20 years, I never had any leak in any of my anastomosis, which is done by this technique. And I'm sorry for the quality of video, because this was very old video, it's more than 10 years. Those days the cameras were not that good, and I was operating in some other city, not in my own center. So this is posterior seromuscular layer, which is complete, and we are almost covering the full length of staple line, so there is no risk of leak. Since it is a revision surgery, you can have edematous tissue or thick tissue. This is a gastrojejunostomy using blue cartridge. I prefer to do a 2.5 centimeter anastomosis, and I always used to close it using a suture. So one can always pass a bougie to check that it is going nicely, and then I always start my closure of the enterotomy from inside the lumen, because angles are most weak area. If we can take care of the angle so well, there is less chances of any leak at any anastomosis. So I started from inside and secured the angle first, and then starting again from another angle and then coming to the middle part of it. So I always do an anastomosis starting from both the angles and then coming to the middle. And one more layer of seromuscular sutures, just to strengthen our suture line. And that completes the procedure. Thank you so much. We can take questions.
Thank you, Dr. Narwaria. Excellent presentation. He has just touched the tip of the iceberg of revisional bariatric surgery. That is a full topic in itself.
Yeah,
if there are any questions,
we can have a 2-day conference only on revisions.
Absolutely.
Thank you.
If there are any questions from the house.
MGB, I do single layer.
MGB is special in all aspects.
Yeah.
Thank you, Dr. Narwaria.
Thank you so much.